Good morning, everybody. This is Dr. Arif Sheikh speaking. And again, I thank you for the invitation to speak at the 7th annual PSNM meeting. I send greetings out to all my colleagues, as well as the new and rising nuclear medicine physicians in Pakistan, and as well as our colleagues in China and from the Arab societies. I will be talking about clinical imaging of infections and inflammatory disorders with PET. I was originally asked to speak about non-oncologic uses of PET, but that itself is a very broad field. I decided to narrow it down to infectious and inflammatory disorders, which itself is a very broad field, and I will try to cover some salient aspects of it in the next 30 minutes. So I have no financial disclosures, but I will be again talking about clinical tracers and uses that may not be currently either FDA approved or approved for reimbursement in the US, whereas they may be approved elsewhere in the world for such uses. So when we talk about inflammation, we're really talking about a newer and non-specific pathology because we know familiar with things like vasculitides and as well as infections, both acute and chronic. But as you know, uh, inflammation now spans subjects such as oncology, cardiovascular diseases, as well as neurology, as when it comes to neurodegenerative diseases as well. But I will not be touching upon those aspects so much as infection and some other vascular inflammatory disorders. So it is salient and important because as of this year in 2021, FDG PET-CT was previously not reimbursable for infectious imaging, but now it is, and in the US. So that is an important milestone and step forward in terms of really using this modality for infectious imaging. So FDG is currently still the most commonly used radio tracer when it comes to PET is concerned. There's cellular uptake related to cellular metabolic rate and number of glucose transporters. Um, and these transporters are basically activated and increased in inflammatory cells, as well as the increase in affinity of glucose transporters for FTG, secondary to cytokines and growth factors, all of which lead to increased FTG uptake at the site of infection. So what are the advantages of FTG over SPECT tracers? Well, a lot of the SPECT tracers are some sort of ligand or actual labeling of the white blood cells, the leukocytes themselves. So compared to those, FTG is a small molecule and enters poorly perfused regions quite rapidly. And of course, it produces very high resolution images with high sensitivity. There's minimal uptake in normal bone marrow, low uptake in degenerative bone disease, and compared to white blood cell labeling, there's no blood handling involved. Now, for example, in fever of unknown origin, radionuclide studies typically performed after all of the tests are negative, but the majority of them yield negative results. So the traditional approach has been doing either indium labeled WBCs or gallium citrate imaging, which can take 2 to 5 days to complete. I understand in Pakistan there's access to ubiquitin as well. But again, all of these have shown some good results, but again, left a lot to be desired. So in the 21st century, FDG really has been making its mark. It's got a high sensitivity and negative predictive value. And even in the setting of an FEO, if you get a negative results, it's unlikely that a focal source of FEO will be determined. And looking at some specific areas, for example, looking at inflammatory bowel disease, there's already been a fair amount of extensive work done with labeled WBCs, and we can see that it is fairly sensitive in monitoring things like Crohn versus colitis and measuring treatment response and things like that. With FDG, we know it's very sensitive, but perhaps in some ways almost too sensitive. So we don't know if it's actually good for monitoring all the issues as has been listed in the table. For example, here you can see a patient on the right side who's a diabetic on metformin. This is a classical picture. Everyone knows that you can get diffuse bowel uptake as a result of being on metformin. It's not an inflammatory disorder. It has to do more with a gathering of glucose in crypts in the bowel. But on the left side, we see a patient with ulcerative colitis, again with diffuse uptake. Now, you might be able to distinguish just because of the pattern of bowel you're seeing, but if you kind of look closely at the bowel itself, you may be hard pressed to distinguish one from the other, especially if somebody who's got ulcerative colitis may also happen to be taking metformin. This is a case actually of a patient with Petamar where you see focal uptake in the abdomen, and in this case, it is unclear what that focus is. It could be nonspecific, and actually, it turns out likewise, the finding in the MR is also somewhat nonspecific. But put the two together, you see there's a focal uptake that would suggest active inflammatory changes in the cecum, and so with the two together, this is easier to diagnose as a focal inflammation slash infection. There's a lot of work also with musculoskeletal infection. Again, there's high sensitivity there. As mentioned, there's minimal uptake in normal bone marrow, but the uptake in uninfected fractures rapidly normalizes within 3 to 4 months. So if you've got issues with chronic osteomyelitis, FDG may be somewhat helpful. We know that FDG is relatively accurate in chronic osteomyelitis as well in those cases. So FDG could be useful as well. So here, for example, we see a patient with a joint replacement actually. And again, the patterns are somewhat different. You see an infected right-sided total knee replacement on the left side, and whereas on the right side you see an aseptically loosened left total knee replacement, which again you can see the pattern is somewhat different, and but again it can be somewhat difficult to distinguish between the two at certain times. Spinal osteomyelitis is another area of significant diagnosis that FDG can contribute to. It is known that, for example, WBCs can have false negatives in those cases, and actually gallium 67 citrate imaging is the preferred modality in those cases. Nevertheless, when looked at with FDG, there seems to be very strong evidence that it has great sensitivity and specificity and accuracy. A lot of smaller studies using small numbers of patients actually showed virtually 100% accuracy, but patients and studies done with larger number of patients showed a little bit decreased accuracy. But overall, if you put these studies together, you still get a very good performance for FDG and spinal osteomyelitis. And this is a case, for example, you can see clear changes on the CT portion on the top row associated with increased uptake. This would suggest that there's active osteomyelitis. Whereas you see similar type of erosive changes in the CT portion of the scan, but the uptake in the FTG shows minimal to no uptake, potentially a small focal area of osteomyelitis, but overall there does not seem to be any active osteomyelitis that we really see. Vascular graft infection is another area of great concern, but this is unfortunately a little bit more limited. There have been several studies that have looked at this. For example, they've shown that just the vascular grafts themselves can have uptake, and this is thought to be due to endothelialization of the graft into the vasculature, and unfortunately that can cause chronic uptake. So out of the 16 grafts that were looked at in the first study, only one was actually infected, although all of the 16 grafts had uptake. And likewise, if you look at the FTG portion and compare it with the CT portion of the scan, if there is uptake as well as CT findings suggestive of infection, then the positive predictive value is very high. Likewise, if both scans show no evidence of infection, then the negative predictive value is very good. The problem is those cases where they're discordant. But nevertheless, it's still in 75% of the cases, you can still get a definitive diagnosis, which means discordance occurs in about 25% of the cases. It's kind of high, but the good news is that at least most of most of the cases, you can make a fairly definitive diagnosis. And just going forward, looking at 16 uninfected vascular grafts, you can see that there's various patterns of uptake that are seen, and even looking at SUVs, that really doesn't help distinguish between what may be infected or not. And there was been, over 2 years, there was no change in uptake seen over that time. Here is an example of a patient followed over a 1 year period, showing increased uptake in the vascular graft on the top and subsequently on the bottom. And again, there's been no change between the two grafts over time. And this is actually an asymptomatic patient, a patient with no signs of infection whatsoever. But there are other areas where FDG PET is making perhaps a greater impact than the traditional imaging methodologies, such as in myocarditis. It's quite important. There are several etiologies for myocarditis, specifically the infectious kinds. There's also, other things like cardiotoxic exposure can also do it. Nevertheless, the problem in myocarditis is that active inflammation can lead to cell death, and as well as in other active inflammatory disorders. So, because of the cell death etiology, it is vital to find and diagnose myocarditis as early as possible. And this is just a timeline of what can happen. For example, if you get a viral myocarditis, you get the acute myocarditis syndrome within the first 4 days, where you have a massive release of cytokines and interleukins, tumor necrosis factor, interferon, and which do start help clearing the virus after 4 days. But what you're starting to see is, as all these mononuclear cells and lymphocytes, antibodies are infiltrating, you start getting a lot of cell death. You get a subacute myocarditis picture, so that after just within 2 weeks of the viremia, you start getting fibrosis of the heart, cardiac dilatation, and heart failure. So you really have a very short time to quickly diagnose and start treating the cardiomyopathy as soon as possible in order to prevent myocardial damage and myocyte damage. Here's a case of actually a PET-MR looking at it, where you see late gadolinium enhancement in the area of concern on the top, and there is focal uptake that we see in FTG, and this is with the clinical suspicion of myocarditis. This is diagnostic for that, and you can see the effusion image, and the last image actually was taken with a PET-CT image, but that was actually acquired before the PET-MR. So even though you don't see it on the PET-CT, it's quite possible that because the PET-MR was acquired in a little bit more late compared to the PET-CT image, that there was a chance for the area of infection to take up the FDG. But it's unclear whether how much of the technology actually played into that in being able to find the focal area of abnormality. Nevertheless, not only myocarditis, but endocarditis and pericarditis is another area where PET can make a big difference. Again, in those cases, it's a quick and easy study to perform. Compared to white blood cell imaging, again, you improve your sensitivity significantly. But you can, because it is a whole body scan, you can find out other areas of embolic disease. So when the diagnosis is a little unclear, if you find signs of an embolic disease, that will further improve your positive predictive value. As for pericarditis, it is quite sensitive for pericarditis inflammation, but unfortunately not specific for infection. And we can see that the sensitivity, specificity, and overall performance is pretty good here. It's not great, but it's pretty good in terms of use as a clinical tool. Here we can see a patient with an endocarditis. You can see focal uptake in a patient who's had a Fontan procedure in the past. There is an abscess that we can sort of appreciate a little bit on the CT portion, which does light up around the area of the device, and confirming that the patient indeed has an endocarditis. This is another patient actually with a vascular graft. We can see uptake around the vascular region, the graft region in the vasculature, quite visible, quite obvious, showing signs of an active infection. This is another patient with an endocarditis, but on top of that, there is a focal uptake in the disc suggestive of spondylodiscitis, which would suggest the patient has septic emboli. And this is a patient who had a septic embolus to the spleen. And finally, this is a patient who had an endocarditis, but we can see focal uptake in the lung, which actually is suggestive of a thrombotic pulmonary septic embolism. With regard to, it's a pulmonary septic embolism that is sent to the lungs, and you can see focal uptake. So again, all of these findings, if you see any of them or all of them, would support your diagnosis of endocarditis, especially if the diagnosis may be a little bit unclear on the FDG PET. And endocarditis in the use of device infections is uh, is quite important because as much as devices are put in, they are susceptible to have infectious organisms being introduced into the body. And in this case, we can clearly see there is FTG uptake around the device, even though it's a metallic hardware there, and you can sometimes get artifact. Nevertheless, the uptake is relatively intense that you should be able to make the diagnosis in most cases. And moving away from infection a little bit, this is actually the detection and prediction of bioprosthetic aortic valve degeneration itself. So you can look at somebody who's had a prosthetic valve, and over time, as that starts to degenerate, you can track it and see when a patient may actually be eligible to have a valve replacement done again, a redo. In this case, this is done with sodium fluoride imaging, and so the degenerative process causes calcification of the valve, and as that progresses, that can be seen on sodium fluoride. So vasculitis is another area of that FTG PET has made great inroads because vasculitis often shows up as a fever of unknown origin and is one of the differential diagnoses. So PET is quite sensitive for that and can actually help find these etiologies and separate them from infectious etiologies in that matter, but it is usually for detecting large vessel giant cell arteritis or vasculitis. It's less useful in patients who have medium to small vessel disease or who are immunosuppressed. So basically, patients who are newly diagnosed and have not had therapies for their vasculitis or for suspected vasculitis are more easier to find. But the other advantage is once you've found it, they help you monitor and respond to therapy. And these are a couple of cases a little bit more close up with regards to a patient with vasculitis. Now, ordinarily on an FTG PET scan, you should not see the aorta so prominently, but in this case, we see it not only prominently, but we see the vascular walls around the large vessels quite prominently, and you can see the others. Medium-sized vessels and somewhat smaller vessels light up, and in conjunction with the aorta, this is suggestive of vasculitis. And in fact, you can see that this focus right here is actually the left main coronary artery, which is also lighting up as a result of the vasculitis. And again, similar kind of picture, kind of showing you from a different angle all the different vessels that are lighting up uh, and involved in this disease process. This is a case where a patient was suspected to have vasculitis and had an MRI study looking at the vasculature, and everything looks actually absolutely normal. Again, we don't see any evidence of enhancement or thickening of any of the vascular walls or vasculature in general. But that patient went on to have an FDG PET scan and clearly shows evidence of a vasculitis as the aorta lights up all the way from the thorax, aortic root all the way down to the bifurcation in the abdomen. And not only that, you can use it for therapy monitoring. So once the patient's been in immunosuppressives, there's marked improvement. There is some residual uptake, but overall there's been a marked improvement. Again, something that you may not be able to track with MRI because even at baseline, MRI was negative. Moving on to other entities such as sarcoidosis. Sarcoidosis is an inflammatory disorder which, when active, is quite exquisitely sensitive for FDG PET, and we can look at pulmonic disease and extrapulmonic disease and extensive disease, and we can use it for therapy monitoring. But one of the very tricky areas of sarcoidosis is actually making a diagnosis of cardiac sarcoidosis. There are various societies that have um, developed guidelines on how to make that diagnosis. Cardiac sarcoidosis can be somewhat difficult, but nevertheless, there are criteria with regards to looking at echo findings and MRI findings, but also nuclear findings. For example, in the Japanese society, you can see there's uh, use of gallium-67 is approved, or even technetium labeled myocardial scintigraphy or thallium myocardial scintigraphy is approved, and likewise FTG it can be used. In the Heart Rhythm Society expert consensus statement, again, there's a lot of characteristics using as MR, but also with certain patterns, as well as positive gallium uptake, which all of which can be used towards explaining sarcoidosis. So here are four cases where you might see cardiac sarcoidosis. For example, four scenarios when you're looking at these are the patterns you'd come up when you're looking for sarcoidosis. Usually, you will do a perfusion myocardial perfusion scan. So in this case, it's done with ammonia. You can see in the first one, the on the left, the ammonia perfusion scan is virtually normal, and the FDG portion shows a lot of blood pool activity, but really no uptake in the myocardium, which you can see is actually the negative image of the perfusion scan. Really no uptake in those areas is considered normal. Here on the second one, the ammonia uptake is relatively normal in the myocardium, but we see that there's uptake in the lateral wall in FTG, and you would think, okay, this is focal, this may be uh, consistent with sarcoidosis, but generally speaking, sarcoidosis is not going to be found on the lateral wall. If you actually do see this pattern, this is considered non-specific and maybe due to insufficient preparation of the patient prior to the study. The dilemma is that in certain cases, yes, you can get sarcoidosis looking like that, but more often than not, this is not going to be sarcoidosis. Again, if you got a high enough clinical suspicion, you would suspect sarcoidosis in those cases. In the third case, where you actually have septal uptake, an isolated septal uptake with normal perfusion, that, on the other hand, is more consistent with a sarcoid picture and would be called most of the times. Whereas in the last case, where you now have a perfusion defect and really no FTG uptake, that is actually caused by an infarct. Given the dilated heart, you would think this is ischemic disease, but again, this could very well be an inactive sarcoid that has caused a local infarct. So again, you may think this is ischemic disease nor sarcoidosis, but again, the patterns aren't completely specific rule in or rule out sarcoidosis. Nevertheless, there are things that can assist you, even then sway you towards one diagnosis of yes or no. For example, this is a patient with a rubidium scan, and we can see there's a little bit of a defect in the septal wall, which corresponds to focal FTG uptake. And there's uptake in the lateral wall too. But in this case, we would call this sarcoidosis, especially if we look at the whole FDG PET scan. We can see there are several other areas of sarcoidosis involvement as well. So putting that all together, it raises the likelihood that what you're looking at is active sarcoid uptake in the PET scan. Likewise, this is a case where focal uptake is in the RV, and even that has prognostic significance. You see septal uptake, RV uptake, and again, widespread uptake elsewhere consistent with sarcoid. So certainly this is a picture that can yield a lot of diagnostic findings. Um, Nevertheless, there have been studies looking at MRI and comparing it to PET and just looking at outcomes. So, for example, if you do not have late gadolinium enhancement, patients tend to do very well in terms of having any events from their pacemakers or anything like that. Whereas if they have abnormal enhancement in MRI, they've been further split down to whether they had FGG uptake and no uptake. And one of the surprising things is, despite whether or not the patient has uptake or not, the overall outcomes of this patient in terms of annual event rates, cardiac event rates as a result of sarcoid are virtually identical. This has been confirmed by other studies as well, where you can see that enhancement patients who do enhance versus don't enhance do have a survival difference between the two categories. And if you look at the PET side too, if you look at those with FTG uptake, normal PET and normal PET on the top and with uptake, there's a survival benefit there too by PET by itself. But if you further stratify these patients based on enhancement or non-enhancement and uptake or no uptake, actually it turns out the FTG PET uptake does not predict any better or worse survival. And the most powerful prediction in this case is the MRI. So, what is the use of FTG PET if MRI seems to make all the difference? Well, if the image is somewhat inconclusive, you can certainly do an FTG PET. But if you do get late gadolinium enhancement, really the FTG PET is there to see whether or not the patient, there is a role for immunosuppressive therapy at that time to try to save as much as muscle as possible. At the end, they both may both burn out or scar if you do not treat the patient. So again, as I mentioned earlier, the goal is to try to save as much muscle as possible. But as far as technology is concerned, I've shown you a few slides of it, but PET-MR itself is a newer modality. You're taking the advantage of the sensitivity of PET and specificity of MRI, although MRI itself has a lot of sensitivity as well in lesions that may not be active, such as in sarcoidosis. It's likely optimal for soft tissue lesions. It's superior to PET-CT for bone infections, but has limited utility for device infections due to all the artifact that you may get on the MRI portion. And then, of course, it's a very expensive tool, so we do not know whether it's a cost effective for these indications. Nevertheless, this is a patient with a necrotizing granulomatous inflammation, which we can see in the MRI and clearly matches, in this case, a gallium dotatate PET has been done, and we can see that matches the inflammation. But we can also see, focal areas of inflammation that on the MRI looked a lot uh, less specific. They're very non-specific findings. Could be some vasculature or other things. Could be just CSF. But in this case, because of the focal uptake, this confirms that the MR indeed has other sites of inflammation that would otherwise might have been overlooked. This is a case of spinal osteomyelitis, and unlike the case I showed you previously, here we can see there's some changes on the MRI that just sort of somewhat equivocal changes that would suggest that there is infection. And if you look at the FTG PET by itself, again, there's sort of some focal areas. Just looking at the FTG PET by itself, you may not really appreciate it, but put the MR and PET together, you realize those changes, and the FTG PET we're looking at are going to be small areas of inflammation that consistent with acute infection. So again, really does raise the bar in being able to find sites of infection. But now, of course, there is development of a lot of tracers here. You'll see both on the PET and SPEC side. And because no one tracer right now seems to be the magic uh, diagnostic tool in order for us to be able to diagnose and differentiate infections. So, what do we really want to do for this pharmaceutical to do? Obviously, it has to be safe, specific for infection. It has to be quite available to everyone. It should be a rapid test, and of course, yield high enough resolution images so that we can make definitive diagnosis as to where the infection is. This is actually FDG labeled WBCs. So it looks like a white blood cell scan, except it's labeled, the white blood cells are just labeled with FDGs. It's not a very difficult procedure to do. And again, what we see in this case is basically a white blood cell scan on PET labeled FDG, and we can see there's focal uptake in this case, which shows that this is indeed a bacterial endocarditis. Another case where a patient has a Charcot joint in question of osteomyelitis, the top set of images are really sodium fluoride PET images are showing uptake in a lot of the joints consistent with the Charcot joint. So nothing clearly localizing to suggest an infection. When a WBC, FTG labeled WBC scan is done, what we show is see is what is shown here is that there's uptake in the um, soft tissue, which would suggest that there is just focal infection and no real evidence treatments for osteomyelitis. Gallium citrate has been used a lot on the SPECT side. Here we use gallium 68 citrate to increase sensitivity as well as resolution. And again, you can use it to diagnose as well as follow therapy for osteomyelitis. This is another case of gallium citrate being used, this time other hardware. You can see uptake before and after curettage showing the osteomyelitis is resolved. And likewise, a patient who's had an MRI with spinal osteomyelitis can be diagnosed with gallium citrate. So we know that FDG PET-CT is a highly accurate modality and PET overall compared to conventional SPECT imaging, but there are some limitations such as graft infections, and it is better in acute versus chronic infections and separative versus non-separative infections. That is true. In some cases, gallium could still be used. But like I said, there is gallium 68 citrate available in case FDG doesn't necessarily seem to work. Gallium 68 citrate is not currently FDA approved as yet. It is a tracer in development. There is a growing impact in cardiovascular infections with FDG PET-CTs, and some newer approaches with PET-MR and perhaps development of newer tracers will certainly help improve the imaging infections. And with that, I'd be happy to take any additional